So the difficulty to treat urticaria patients, or difficult to treat patients with severe urticaria. I'm going to present two cases here, which I've been managing for the last number of years. SA is a 35-year-old female whom I saw in 2018 with recurrent rashes of 4 years. Again, the rashes were typical of chronic urticaria, red raised, itchy, painful, resolved with bruising though. Affecting different parts, no angioedema, no obvious triggers, no relieving factors. She doesn't have any B symptoms. And she has had several antihistamines, and you can see there up to 2 to 3 folds, topical steroids and montelukast without any effect. Now, review system was unremarkable other than fatigue, and she was really under a lot of psychological and emotional stress. She's a very healthy lady and no other past medical history of note, or no significant family history, because remember now, urticaria can actually, there is a family history, there is a familial urticarial type, and I have in Cleveland Clinic about 4 families with 3 or 4 family members affected by chronic urticaria. And there is a study that was suggested to actually look at these families and see if there is a genetic common component or genetic element to these patients with familial chronic urticaria. Now, this is her skin, so red raised, itchy rash. And so we did a few investigations there, and you can see that her TPO antibody was positive. She had marginally raised total IgE, and the rest of her investigations, including the C1C chronic urticaria index, was negative. So this lady has a chronic spontaneous urticaria, Hashimoto's thyroiditis, and emotional stress. And so we have the options there. So because of her stress element, I said, well, look, we'll try the tricyclic antidepressant, doxepin. Once you mention, and I'm sure that happens to you, once you mention these medications are for depression, patients will look, doctor, I don't have depression, and they are reluctant to use these types of medications. So anyway, the other options are either omalizumab or cyclosporin. So we opt for omalizumab actually, and she was treated or initiated on omalizumab 300 milligrams every 4 weeks. 2 months later, there's nothing really happening to her urticaria. She's still, UCT score is low, 2, and we decided to bring omalizumab to every 2 weeks. Few months later, her urticaria control test was improving, and we continued omalizumab, but at 4 weekly intervals. Did well over the years, and we decided to increase or to reduce actually the frequency of omalizumab to every 6 weeks, and again to every 8 weeks, and until November 2021. I suggested to stop omalizumab after 3 years of usage. And she basically denied stopping it. She said, look, doctor, I don't want to go back to my previous life where I had significant disease, and I'm not gonna, risk it and be miserable again. I have enough stresses in my life, so I don't need the stresses of the urticaria. So anyway, we said, look, let's give you the omalizumab every 3 months. And again, to me, this is a placebo effect more than actual, pharmacological effect. I think patients get attached to these medications, and we're lucky here in this country where we can use these medications liberally. In other parts of the world, we wouldn't have that freedom to use these biologics for a long period of time like this. So anyway, we continued giving her every 3 months, and she's been doing very well. She had no treatment adverse effects, no safety concerns for about 3 years at this stage. Now, the other interesting, this is really a very, very interesting chap whose name is M.A. And it's not Mohamed Abuzakouk, it's Mohamed M.A. Anyway, so his name is Mohamed, but I'm not going to share the surname. So he's a 33-year-old Emirati chap, very pleasant man, who I saw in May 2018. It was a rheumatology referral. And again, this guy had these rashes for about 8 years. Now, red raised, itchy, painful, resolves with bruising again, affecting his forearms and legs, no angioedema, no obvious trigger, no B symptoms. He was never given an antihistamine, believe it or not. and no effect from local steroids. This guy on system review has intermittent joint pain, but minor. There's nothing really significant there. And he had reduced hearing on his right ear. And otherwise, he's a very smiley chap. You know, he's a pleasant, really very young man. Now, these are his lesions. So you can see his hyperpigmented dark areas and scars on his ankle and dorsal feet. And these are you know, urticarial, if you like, vasculitic lesions. And you can see the bruising on the dorsum of the left hand and his left forearm. Now, we did, again, lots of blood tests here, and you can see that his C4 was slightly reduced, nothing dramatic. His total IG was, again, slightly up, but he had a positive chronic urticaria index, implying that this patient has autoimmune urticaria. So, okay, so this is a relief. We know now what's going on with these patients. And again, look, we did a lot of investigations, including C3, C1q levels, you know, a lot of stuff. I think even cryoglobulins we've done because he is unusual chap, you know, and we just didn't know what's going on there. So all of these investigations were negative, bar the three mentioned above. Now, interestingly, he had a skin biopsy that showed leukocytic plastic vasculitis. So this is an autoimmune type urticaria vasculitis. So, okay, so it's an autoimmune urticaria vasculitis, and the other differential here was hypocomplementemic urticaria vasculitis. This is really unlikely because if you look at the characteristic features of hypocomplementemic urticaria vasculitis, you'd find that in hypocomplementemic urticaria vasculitis, you know, the C1q antibodies is present in 100% of patients. So all patients with hypocomplementemic urticaria vasculitis would have anti-C1q antibody. And this guy's anti-C1q antibody was negative, and he had normal C1q. So these are the cardinal features of hypocomplementemic urticaria vasculitis. In addition to that, his C4 was marginally reduced. In patients with hypocomplementemic urticaria vasculitis, C4 would be markedly reduced, but his was marginally reduced. So it's very unlikely. It's probably autoimmune urticaria vasculitis, is what this guy has. So again, the treatment options we have either to put him on an immunosuppressive agent, oral steroids, antihistamines, tricyclic, a combination of the above, and omalizumab. So what I decided to do is to put him on omalizumab, and we started this in June 2018. We gave him 300 milligrams every 2 weeks. He didn't really improve 2 months later, with the new lesions appearing after excessive exposure to the sun and seawater. But he started to improve 3 months after commencing omalizumab. And by October, which is 4 months from when we started, look at his UCT score, it's 15. And he had no urticaria or new lesions, if you like what he used to. So this guy used to see these lesions on his forearm nearly every week or so. Now, these disappeared since commencing omalizumab. And he extremely did very well over the years. And on his recent review, his UCT was 13, and again, 16, sorry, his UCT. And again, we decided to, you know, reduce the frequency of omalizumab to 10 to 12 weeks. And again, he denied stopping Zulia because he said, again, doctor, he lives in Sharjah, and he said, look, I'm not going to stop this medication, it changed my life. I'm better now, and let's continue. So this is his lesions on this is his photograph he took from his phone. There is no, that was June last year, and you can see again the area of hyperpigmented skin, but there's no active lesions. Now, he's attending our dermatology colleagues for this, but I'm not sure if there is any any magic solutions for these hyperpigmented areas, unless you can tell me what we can give him. Now, again, there are no treatment issues or treatment adverse effects, and he's on this for 3 years with no problem. So the take-home message really is that omalizumab is effective, safe treatment for severe forms of urticaria, including urticarial vasculitis. Now, we're actually reporting this case, and it's been accepted for publication with Marcus Moore. Marcus is interested in this because there's no literature. There's nothing in the literature. There are only case reports. I mean, this is probably the 3rd or 4th case report. So Marcus is going to be a co-author, although he's reluctant to be a co-author. He said, look, I didn't do anything with this, but out of courtesy, because he was interested, I just included him as a co-author. And I think reducing frequency, you need to consider reducing frequency of treatment if the patient is doing well. So again, stepping down on treatment when patients are doing very well. And again, as I said, I mean, I'm sending this urticaria control test to you, and I hope I've done a good job to sell it to you that you need to use it in your clinics as an invaluable assessment tool for our patients that will help you, to some extent, to determine whether these patients have a well-controlled urticaria or not. Okay, this is what I have for you. Any questions or concerns or comments? Sure.
One question is based on awareness, the diagnosis.
Yeah, and how is the features of vasculitis?
Because this type of communication is independent
Right.
of vasculitis and this long duration. To maintain this type of communication to the very kind of diagnosis.
Absolutely. You mean worry of the vasculitis?
And this part of the communication looks like a liver protection of the skin, which goes most with vasculitis.
Oh, right.
Rather than kind of steady, pathological changes in the upper dermis within the dermis function.
Yeah, so the urticaria vasculitis was based on the biopsy, but before the biopsy, we had this serology. So there is an element of vasculitis there. Reduced C4 is urticarial index is positive, which is indicative of an autoimmune urticaria, plus the skin biopsy. So, so all in all, urticarial vasculitis, autoimmune urticaria. Now, not lichen planus, but the other lichenoid. Yeah. So in my view, lichenoid would respond to topical steroids and oral steroids. In this case, I've been using these medications for 8 years in and off, and there's no benefit. So he was put on omalizumab and it changed his life actually. But no, his concern is these hyperpigmented lesions. Is there a magic thing to be done to help him? Excuse me. Let's fit with the doctor first.
I think that actually one is urticaria and the other one is urticaria. But my concern was that how do that happen after it's feedback for
In my view, this is post-inflammatory change. So there's no active disease there. So what are we dealing with is a post-inflammatory skin changes. Now, what are you saying is that you think there's a third element to this?
I mean, he has yes. And my question was that cardiovasculitis diagnosed is a biopsy?
This is why I said confirmed about the blood test, and we have 2 elements. Yes,
That's right.
So yeah, maybe one explanation for higher that long time
to that extent, it becomes different. I think it causes hyperpigmentation.
I saw one case really 2 years story, you have more than this. And you wait for days are also
Okay. Any questions?
I just have one comment on direct savings on our care customer. Of the 8 hours.
Correct.
I have childhood things like and he had since and like 6 years and he developed chronic spontaneous and he had this little also. And the other dermatitis now become so mild, but the problem is the main problem chronic spontaneous activity. So here, like when we start, like my one is like there's a mild
so again, what we said, what is the dominant problem here? Is it chronic spontaneous or is it atopic dermatitis? What's the dominant? Because I will use, because it will work on just indirectly on the atopic dermatitis. Although there are studies now, like I showed you there, there are studies to show that Dupixent or Dupi is coming along for urticaria as well. So, but for the moment, the only licensed biologic is the omalizumab. So I'll use omalizumab in this case. Yeah, and it'll help his asthma, like Dr. Hamad said, yes. Is that clear? Yes. What do you think? You don't seem convinced.
In such patients, we were like, what do you use? We use omalizumab and have good response, but unfortunately,
well, that's the problem. And this is the problem I'm sure you're facing it is that patients get better, they become lax, they don't attend their appointments. And this is a major issue. Compliance is a big thing. So, but again, what's the dominant feature here? Is it urticaria or atopic dermatitis? And both work. Omalizumab and Dupi work for both atopic dermatitis and urticaria. But the FDA approved, the one that the insurance will reimburse you for is the chronic urticaria. Ravi, any questions, comments?
No, it's very clear that atopic derm is minor and is obvious. And where are we in terms of the dupilumab urticaria trials? Hopefully, there are phase 2.
I think it's currently more or less done. I think we're waiting for it to be. Oh yeah, done. It's all done.
I think the case is publication, and then someone was asking me like 3 cases.
I think it's coming this year or something like that. I think it's FDA approved or it's in the process, so it is going to be around. I'm not sure. Have you had any experience with Dupi in urticaria?
I had the urticaria was really visible in urticaria, so each patient respond to very much. This will be my first choice of matching group. This is published literature on the effective treatment in the absence of actually skin sign. So in such cases, I would actually go.
The main case is it's not that, and the semi-lying patient has some infrequent things. So possible.
So I guess later on the challenge will come to us.
Both are available, both are approved, which to start. So then I guess we need to And, asthma with biologics, have a biomarker approach. But if we go with the basic biological, immunogenesis, so is mast cell activation totally dependent on IL-4 and IL-13 induce, the IgE production and sitting on the mast cell receptor and mast cell activation because of that. If that is the only pathway, then yes, dupilumab should answer support area. But I guess given the sandwich is quite heterogeneous and also having very different response, I'm sure like we have a responding on the sort of in terms of dupilumab and bacteria. But otherwise, yes, we should be the game changer. You're blocking IL-4, IL-13. You're not going to let patient look class switching and produce IgE on the top of the mast cell. And you're also IL-4 and IL-13, they also promote mast cell activation and also promote the mast cell proliferation. So you're blocking that. So it should be 100%. But I feel like there will be people who respond excellent, but there will be people who won't respond. So I guess our biologics will have the same test as an asthma, and I guess then we have to rely the biomarker approach or look at CA index or move and we go over this now. But I think it's interesting.
Yeah. So I mean, the take-home message is that watch this space. There is a lot of biologics coming in your way, and watch it. So be prepared. And really, we need to develop guidelines, either international, local, etc. On what fits what patients, what biologics actually works for what patients. And this is a dilemma we're facing in terms of asthma. So in asthma, we have lots of treatment, the same biologics available. And the dilemma is going to be even further for the urticaria, because this is just to give you a sort of a snapshot of what's coming up in your way.